Absolutely. So trastuzumab-based therapy is approved in first-line setting in combination with platinum therapy. Trastuzumab Deruxtecan is an antibody-drug conjugate against HER2 that is approved in second and beyond after trastuzumab failure. So early on, we wanted to develop a strategy to bring T-Dxd to first-line setting. And of course, to do that, you first have to demonstrate feasibility in combination with fluoropyrimidines because they're so important in first-line setting for gastric cancer. So DESTINY-Gastric03 explored combination monotherapy of T-Dxd in first-line and also in combination with capecitabine and pembrolizumab. Oh yeah, that's a great question. So of course DESTINY-Gastric03 was not powered to directly compare efficacy, but what we see that T-Dxd monotherapy has single agent activity. The overall response rate is approximately 50%. It's a small subgroup, some small group of patients. Combination of T-Dxd plus capecitabine appeared to be really have more efficacy with progression-free survival of 20 months. So I think T-Dxd monotherapy has definitely activity in first-line setting, but probably would be insufficient to replace for platinum-based therapy in first-line. Absolutely. So as you saw early on in our study, we really demonstrated that T-Dxd 6.4 mg/kg plus capecitabine was feasible, and then we started building on it in combination with pembrolizumab. Unfortunately, T-Dxd with capecitabine and pembrolizumab proved to be too toxic. The triplet regimen at full doses was too much, with increase in grade 3-4 toxicity, increase in grade 5 toxicity, so treatment-related deaths, particularly interstitial lung disease. So because of that, we've amended the study to include T-Dxd at 5.4 mg/kg with capecitabine at 750 milligrams per meter squared with pembrolizumab. And after 5 months follow-up, so far that arm is quite well tolerated, and the waterfall plot and response rate is quite promising. Particularly, as we see the data is emerging, survival data is not yet mature. So the future will involve triplet regimen in phase 3 setting at lower doses. The combination with immunotherapy is so important in first line, so we are combining it with immunotherapy. Yes, DG03 is not a practice-changing study. It's a study to inform future phase 3 studies. I don't advocate using T-Dxd in combination with fluoropyrimidine in first-line setting. I wonder if in the future some doctors may consider using it in second line in combination with fluoropyrimidine, but that would be not standard. Most patients receive capecitabine or 5-FU in first line. Absolutely, great question. We have DESTINY-Gastric03 additional arms, part 3 and 4 and so forth, and they're including patients with HER2 low population, so not HER2 negative, although maybe HER2 negative by standard use, but HER2 low, so IHC 2+, FISH negative, or IHC 1+ patients. Because T-Dxd may have activity in those combinations, especially when in combination with capecitabine and immunotherapy, we're exploring 5.4 dose of T-Dxd in HER2 low population in combination with other agents.